Welcome to a new and unique installment of the Dutch webinar series. I'm Dr. Allison Smith, the clinical team manager here at Precision Analytical, creators of the Dutch test. In today's webinar called Unlocking the PCOS-Autoimmunity Connection, Insights from the Dutch Test, we're excited to welcome our founder and CEO, Mark Newman, plus one of our fabulous clinical educators, Dr. Kelly Ruef. In this webinar, Mark and Dr. Ruef will take a deep dive into the complex interplay between PCOS and autoimmunity. They will examine Dutch test patterns that may reveal a heightened risk for autoimmunity in PCOS, with a focus on estrogen, progesterone, the PGE2 ratio, and estrogen metabolism. While some women with PCOS don't present with abnormal estrogen levels, a distinct subgroup exhibits unique estrogen patterns that are critical in assessing their vulnerability to autoimmune conditions. They'll explore how key elements of the Dutch test offer essential insights into these intricate relationships and their implications for effective clinical management. We're glad you chose to join us to gain valuable insights into a more effective and integrative approach on this subject. Mark has spent nearly 25 years developing and directing 24-hour urine, organic acid, and salivary hormone testing labs. His unique experience led him to begin his own lab, Precision Analytical Incorporated, to create the most comprehensive functional hormone test available, Dutch, a dried urine test for comprehensive hormones. His vision for a better way to test hormones drove Mark to co-write multiple peer-reviewed research papers, which prove the effectiveness and accuracy of dried urine testing to comprehensively evaluate hormone health. Mark is committed to making it easier for patients and their healthcare providers to answer complex clinical questions through extensive education on validated hormone research. Every day, he and his team of experts work toward their mission to profoundly change one life and then a million more through industry-leading functional hormone testing and education. Dr. Ruef is a licensed naturopathic doctor who studied at the National University of Natural Medicine in Portland, Oregon. She completed a residency focused on inflammatory bowel disease and women's health. Now a clinical educator here at Dutch, she educates how urine testing can support hormonal health. With a background in biochemistry and cell biology, Dr. Ruef shares her passion for hormones and wellness through videos, blogs, social media, and podcasts. If you're ready to start using Dutch testing in your practice, sign up as a registered provider today. Click the link we've posted in the chat and complete our provider application form. A member of our onboarding team will walk you through the steps to set you up an account so you can begin taking advantage of all the education and all the resources that Dutch has to offer. Plus, registered providers gain access to our entire educational library, including courses like Introduction to HRT, Mastering Functional Hormone Testing, the Dutch Interpretive Guide, and one-on-one clinical consultations with Dutch educators. This dedicated support and education is designed to help you become the hormone expert. If you have any questions as we go, please submit them and we'll do our very best to address in the follow-up in the days ahead. So be sure to follow us across all social platforms to stay up to date. It is a pleasure to have you with us today, Mark and Kelly. Take it away.
Thanks, Dr. Smith. Happy to be here today and super excited to be talking about with you all some data that is relatively new to me. I think some of the nuggets we're going to share with you today, even if you're well versed in hormone testing, and we're going to be talking about PCOS, I think you'll find some new information that might help you in treating a subset of those patients, hopefully more effectively as we go forward. I've got Dr. Kelly with me today because as we get into the clinical side and how do we treat these patients, as a chemist, that's not my forte. What I want to do is dig into the data, what the literature is telling us in terms of overall patterns, and then we're going to, I think, dig into some interesting patterns that you're going to see on Dutch testing and testing more broadly that I think will be really interesting as it relates to the connection between PCOS and the development of autoimmunity. So let's get started. This is the paper that kind of started this conversation for me, and we'll come back to this, but the topic is Hashimoto's, PCOS, estrogen, progesterone. Like, how do these things sort of triangulate in terms of risk and disease progression and that sort of thing. And so I think you'll find it's really interesting. Um, what they showed, which was not surprising in this study, is that when you look at the androgens in the PCOS crowd and the controls, the PCOS crowd tends to have more androgens. We see that in our testing. You see that in urine. You can see it in serum. That's well established. When they looked at progesterone, also no surprise, you're getting lower progesterone generally and higher rates of anovulation with your PCOS crowd. So a huge difference in terms of the average control progesterone value in the luteal phase and progesterone value for the PCOS patients in the luteal phase. But when they looked at estrogen, this is not a very interesting tease. This is going to get more interesting. What we see is, as a class of women, the PCOS crowd is not statistically significantly different than the control. But what we're going to see is there's a subpopulation in here that's going to tease out some really interesting information I think will be super helpful to you. So before we get into that, I do want to go through just what, as a class of women, do PCOS women tend to look like in terms of hormones, hormone metabolism. So we're going to go through that. I would say briefly, we're going to hit quite a bit of information, but we're going to try to fly through that kind of quickly just to give us all the same baseline of what the PCOS crowd tends to look like relative to healthy controls. And then we're going to get into the core subject for today. But before that, do want to just point out that even the PCOS group as a group are also made up of subgroups. It's a complex um, state condition. And so we want to make sure that we're clear on that we do have some women who have ovulatory dysfunction, who have high androgens, who have polycystic ovaries, and then we get different combinations of this. And those different groups are going to present differently. And of course, individuals are going to present differently from each other. But I just want to acknowledge that before we go into what, as a larger group, PCOS women tend to look like when it comes to hormones. So just broadly, we've got serum, saliva, we've got the Dutch test for dried urine. In serum, just kind of, again, just broadly when it comes to hormones, we can look at E2 and testosterone and DHEA or DHEAS and progesterone effectively in serum and also in the Dutch test. When we go to cortisol, obviously serum is going to struggle. The cortisol data really doesn't have as much value in serum as it does in either saliva or dried urine. When we move to saliva, we do get a nice picture of the free cortisol pattern. Of course, in the Dutch test, we're going to open that up by adding cortisol metabolites as well. Historically for me, I've not been a fan of using saliva testing as much for the reproductive hormones because the analytical accuracy just struggles more at those low levels to give you good actionable data. And then when it comes to the Dutch test, what was really interesting with this is I started with one interesting finding and then started digging a little bit deeper on PCOS as a condition and what all of these things that we look at on the Dutch test, what those look like. And so we're going to unpack some of those really briefly, just because it really is, to me, fascinating how many of these different things that we look at on the Dutch test have a unique story for PCOS women as a group. And some of that's really interesting and useful and leverageable for you as you treat these patients, again, as individuals. So we'll get into some of those individual ones. Some of the big, broad, basic facts about PCOS and women with Hashimoto's. PCOS, the most common endocrine disorder for females. It's much more common for women to get Hashimoto's than it is men. And that's interesting as it relates to the hormone picture. The hypothyroidism that often accompanies Hashimoto's might lower SHBG, which, so if you lower your SHBG, you're going to get more of your free testosterone available. So that high androgen impact gets worse often when you have both an autoimmune condition as it relates to thyroid, which can lead to hypothyroidism. And then what's really interesting is Hashimoto's then being more common in women with PCOS. And so we're going to pick a little bit today at the why question of why women, or at least one particular reason that I found really interesting, that women with Hashimoto's or women with PCOS tend to get Hashimoto's as a much higher rate than women who do not have PCOS. So I'm going to show you first just the different patterns that tend to present themselves on the Dutch test. But one thing that's exciting that I have to sort of tease here, since this is coming out right before we have a pretty significant update to the Dutch report, is I want to make sure that you're aware as I'm showing you those, that you see those new elements and can interpret them appropriately, but also that's going to act a little bit as a tease for what you're about to experience in your patient's results. So let me just show you those real quickly because I'm super excited to get these into our Dutch providers' hands to really aid with the interpretation of the results. So first thing we that we're looking at is embedding the post and the premenopausal range for the androgens in right into the dial the way that we have for the reproductive hormones. So if you look at progesterone, you can see the luteal range as it's been is so the new look and feel, as you can see, looks much more 2025 and a little bit less 2013 when we first launched the Dutch test. But as you look at the progesterone, as it's always been, between those stars is the luteal range for progesterone. And then down in that purple band there, you can see the postmenopausal range. And of course, historically, we've made a big deal, as we should, of the fact that, particularly for estrogen, when you look at the luteal range and the postmenopausal range, that they separate, and they should, because that's biology, is that the luteal amount of estrogen or progesterone that a woman makes is much higher than what they make when the ovaries give way and the ovaries are no longer producing estrogen and progesterone. And what we haven't done historically, that we're going to begin in May as we launch this new version of the report, is showing the post and the premenopausal range for testosterone. What you do see here is they appropriately overlap, because there is overlap between the amount of testosterone or any of the androgens that women are going to produce in the postmenopausal phase. So just with a quick glance, you can see where a woman's results sit relative to the overall range, as well as the young healthy range versus the postmenopausal range. So you can expect to see that soon. The other thing that we've added is an actual calculated value for, well, not value, but a calculation of the cortisol clearance rate. So when you look at on the report at free cortisol and metabolized cortisol, as we've stressed over and over again, is the better marker for overall production. That's glandular output, whereas free cortisol is how much is available to the tissue. So what you've done historically is you've just stared at that and said, oh, in this case, the free cortisol is right down the middle of normal. The metabolized cortisol are high normal, almost elevated. So then that infers that there's an elevated rate of clearance for cortisol. So what we've done for you is just done the math for you, which looks at the cortisol metabolites on the top of the fraction, and on the bottom is both free cortisol and free cortisone. And so in this particular case, it's listed at the 78th percentile, which means for this particular woman who's got a free cortisol total of 102 and a metabolized cortisol of 6423, that puts her at the 70, higher than 78% of the population as it relates to the clearance rate of her cortisol, which is going to be interesting in cases of obesity, and actually in PCOS cases, hyperthyroidism, or on the lower side of cortisol clearance, hypothyroid, things like that. Also, which is very relevant to this PCOS question we're going to talk about today, 5-alpha androstenediol. I'm going to show you today why that's so relevant, because it feeds right into this PCOS question. That is a marker we've always tested, but it's sort of been buried in the women's report on page 2, where we list the hormones out, and we're going to bring that right to the summary page, because we think the literature really shows us that it's a really powerful marker for intracellular androgenic impact. So we'll go through that quickly. But what do we expect to see on this new and improved summary page for the report for PCOS women? Well, we tend to see lower progesterone. The example here is someone who's in the green. That means you ovulated, but it's on the lower side. We see that with PCOS. What you also see is higher rates of anovulation, where they're clear down in that purple range. That's very common too. Androgens, of course, the androgens tend to be higher across the board in the PCOS crowd. And then I want to look in a little bit closer at specifically what we can see on the Dutch test that gives you even more information on not just androgens, but also the metabolic pattern. So on the summary page, we see total DHEA production. That's the adding up of DHEAS, androsterone, etiocalanolone. So that's adrenal androgen output. Both DHEA and androstenedione, that's sort of the bucket at the end of the day that's catching the three biggest metabolites from those. But what we can also see, which again we want to stress in a PCOS case, is you see how that 5 alpha product of androsterone is higher than the 5 beta product of etiocalanolone. 5 alpha means more androgenic. And so when we look at the 5 alpha reductase activity on the report, in many PCOS women and women who have high androgen symptoms, we tend to see that push towards the alpha. That would be contrasted with a case like this. So if we just take the values away from those two metabolites on the bottom and we swap them. So if we swap those, now we're pushing down the beta pathway. Now we have less of the androgenic metabolites and the differentiation. So in these two cases, we have the same amount of adrenal androgen production, but the way your body is pushing it, the way this woman's body is preferentially pushing that androgen makes a big difference. Why? Because when you push down the alpha pathway, testosterone turns into DHT. And as we all know, it's about 3 times as potent as testosterone. And that really matters in terms of clinical impact for women. Now, this study, which came out in 2018, was really, really interesting to show that in a subset of PCOS women, they have higher levels of all of these urinary androgens. And DHT being the most potent, we tend to think if it's the most potent, that's the most interesting, right? But when you look at it, what we see in the data is that androstenediol, which is the downstream metabolite of DHT, actually is even more meaningful in terms of asking the question, how much DHT is the woman making at the tissue level? And I'm going to show you why that's actually the case biochemically here in just a second. But if you look at the data from this paper, and what I've done here on this little graph is looked at the bottom end of the PCOS range. For each of these analytes, where does the PCOS group start? And then where do the healthy controls end? So I've taken the top of the range for the healthy controls, the bottom of the range for the PCOS women, and what you can see is the only one that's above 100%, meaning there's no overlap between those ranges. If you look at androstenediol, the healthy controls run between 65 and 142, and the PCOS women don't start until 185 and run up to 350. So that's unique for androstenediol, that those two ranges are completely separated. So that's what you can see here is it has unique value for really identifying women who have high androgenic impact. So why do we focus on androstenediol and less so on DHT? I think it's important to actually understand the biochemistry of where this comes from. So we have testosterone gets turned into DHT, right? That's the most potent androgen, and that gets turned into a weak androgen, which ends up being more important. Why is that? You can see here, if you want to look at the actual affinity for the androgen receptor, that androstenediol is a much weaker androgen. So here's why this is meaningful. The most meaningful testosterone is free, right? That's why when you measure serum, you're also measuring SHBG. The Dutch test tends to be a reflection of that free testosterone. It goes into the cell. What happens in the cell? It gets turned into DHT, and the most meaningful DHT is that which is produced within the cell. So what happens, as you can see here, is I'm making DHT via 5-alpha reductase. That hits AR, the androgen receptor, and it really hits the androgen receptor, much more so than testosterone, right? So it hits the receptor. What happens? This is what's key. Within that cell, it gets deactivated to androstenediol. So yes, we can measure testosterone, we can measure DHT, but the DHT that's most meaningful, we see in circulation as androstenediol, which is the conversion of DHT after it's had its activity at the cellular level. And that's why it's a very interesting marker, and that the literature implies that it's more meaningful than DHT itself. So that's, again, why we've pulled it to the summary page for both men and women. It's a very, very useful marker for seeing overall androgenic activity in the patients. And you can see in this particular PCOS case, it's really high, which implies what? that this woman who has sort of high normal levels of testosterone, normal, but on the higher side, when it gets into the cell, it's really getting preferentially pushed, which is common in PCOS women, towards DHT. And that's really important. So we've got elevated DHEA production, high normal testosterone, but lots of DHT being made at the tissue level. Now, we want to get back to estrogen. So, what is it that we see in the Dutch test with estrogen before we show its connection with PCOS and also autoimmunity? So, just to kind of go over what we see here, our primary estrogens, we tend to look at E1, especially E2, but also somewhat E3, looking at all three of these when we're just asking, hey, how much estrogen is this woman producing right now? That's sort of question number one. And this is the format you'll see here is a little bit different than the report as it is now. That will also be a cleaner look for you on the estrogen metabolism when the new report format launches later next month. So we're looking at estrogen status. How much estrogen are you producing? Then two, we want to look at phase one metabolism and then also methylation. So with phase one, we're looking at 2-hydroxy, 4-hydroxy, and 16-hydroxy. Now, there are a bunch of different stories we could sort of talk about as it relates to just relevance of this. But today, the thing we'll probably focus on more is the 16-hydroxy estrogens because we know that those metabolites are more estrogenic. So when we start talking about high estrogen production, 16-hydroxy, if it's also high, is going to exacerbate that. So we'll come back to that in this conversation. But we want to look at how is our 2-hydroxy, which we think of as more protective, how is it competing with the 4-hydroxy, in this case, low, and how is it competing with the 16-hydroxy, again, in this case, relatively low. And then we look at methylation. How is a hydroxy estrogen turning into a methoxy? That's a detox type step that helps protect us. And we know that poor methylation can be due either to genetic impact or nutritional influences. So again, are estrogen levels different in PCOS? As a group, no, there's no, if you look at the p-value here on the right, there's the estrogen levels in this study ended up a little lower at 68 compared to the controls at 88, but no statistically significant difference between PCOS and the controls, but we're going to come back to that here in just a second. Just by way of information, this is actual data from the literature that shows that one of the other things that's different in PCOS women is metabolized cortisol. We tend to think that see that running higher with overweight women, and PCOS women disproportionately struggle with weight. But the study that I found on this actually was looking, because of that case, they were specifically looking at lean PCOS women and still showed an elevation in cortisol metabolites. So we do see more cortisol production in the PCOS group and a higher rate of cortisol clearance. So just that's interesting to know, but doesn't tie into today's storyline as much as it relates to autoimmunity. So I want to talk about two things that might put a woman at higher risk for autoimmunity when she has PCOS. First, studies have found that a lot of women have uncommon emotional stress before disease onset of autoimmunity. So, what does that mean? It means that, yeah, we're going to see these particular patterns in PCOS women. As a group of women, they don't tend to have different cortisol levels. But when one does, meaning when the cortisol levels are elevated due to stress, it's worth paying attention to because that may be a trigger for risk in terms of developing autoimmunity. So that's worth knowing. But what about estrogen? What is the link there? So in this study, what I found really, really fascinating is what we showed before is PCOS women versus controls. Now we're looking at a different differentiation, which is those that have positive antibodies for TPO and those that are negative. So now we're talking about the autoimmunity crowd within PCOS as it relates to Hashimoto's. Only two things ended up being statistically significantly different between these two groups. The one is a given, right? The one you can see in the middle of the screen there is anti TPO, the antibodies. Obviously, that's going to be different when we're looking at because we've separated those groups on purpose. But look at the estradiol. What became uninteresting between PCOS and healthy control is when we took the PCOS group and split them into those that developed autoimmunity, Hashimoto's or not. Now we see a really significant difference in that those that are antibody positive have significantly higher estrogens than those that don't. So what's the link here? High estrogen, and this is the big takeaway that I really wanted to talk to you about today is high estrogen impacts the immune system, making patients susceptible to autoimmunity. So on an individual level with your PCOS patients, that's really important to know. Progesterone adequacy helps blunt the high estrogen effect. So it's not just the estrogen, but it's also the progesterone and the relationship between them. So high estrogen can be dominant to progesterone, as in this case, without estrogen actually being elevated. So if you take the estradiol here and you superimpose it on progesterone, that's kind of how I tend to look at this concept of estrogen dominance. In this particular case, the estrogen is dominant to the progesterone in a relative sense. And what this paper showed is that's really important as it relates to risk of that woman developing autoimmunity. So that's something we really want to pay attention to. And we don't just want to look, this is something that's great about the Dutch test, is we don't just want to look at estradiol, but we can also look at the metabolism for impacts that actually matter there. And to show you that, I wanted to show you a case that was sort of an experimental case for myself. So even though this is a male case, it shows how phase one and methylation play into overall estrogenic impact. So you have a male case here, the testosterone you see at 39, and the estrogens are all relatively normal. The one thing I would point out is the methylation is low. If you look in the lower left, you can see at the 19th percentile, I'm not very good at methylating. Why? Because I have a COMT defect. I have homologous, like a defective enzyme for methylation, and you'll see that throughout these. But watch what happens when you take this patient and you add HCG. So HCG stimulates testosterone production. So let me go back for a second. Testosterone 39, testosterone 76. So a big increase. But what else do we see? The estrogen then, unsurprisingly, although the rate of elevation was surprising, went from 1.2 all the way up to 3. So we see estradiol is high. Here's why the Dutch test is super helpful, as I see it, is yes, the E1 and E2 are high, but what we expect to see is if those are high, we also, if there's a lot of estrogen, we also expect to see high levels of your phase 1 metabolites. Which of the phase 1 metabolites or phase 2 are elevated? None of them, right? So even though our estrogen ratios look good here, this is something that for your female patients, you also want to see is when E1 and E2, or you want to evaluate, not see, you want to evaluate if E1 and E2 are elevated and the metabolites below are not, then that's a picture of sort of sluggish clearance of estrogen. So watch what happens as we intervene here nutraceutically. So here's the next test. So watch, testosterone goes from 76 to 78. So it's relatively the same, right? But the estrogen goes from E2 goes from 3 down to 2. And if you notice at the bottom there, that 2-hydroxyestrogen really popped. So what do you think was intervening here? This happens to be a particular orthomolecular product, but it has calcium D-glucurate, which helps you clear your estrogen, but it has DIM in it, which pushes the estrogen down that 2-hydroxy pathway. And did it ever? Let me go back for a second. So see that 2-hydroxyestrogen at the bottom, 4.58? Now watch that leap from 4.5 all the way up to 8.7. So the estrogen's coming down and it's pushing down that 2-hydroxy pathway because of nutraceutical intervention. So that's how you can use phase 1 metabolism to sort of assess more precisely what's going on with someone's estrogen. But now look at the methylation. Because I've given the methylation more to sort of work on, it's even worse. If I go back here for a second, it's gone from the 11th percentile to the 4th percentile. So the methylation is terrible now. So now we're going to add something else into the mix. I got a product from the same company that has some trimethylglycine in it. But before I started using that, one of our providers actually gave me some trimethylglycine from another company. So that's what I was actually on for this next assessment, but look at the testosterone still right at, it's like the same exact value. Really interesting, great precision from day to day. But look at the estrogens now. The estrogens are in range. They're still high normal, so I might want to, work on some aromatase inhibition or whatever. But the point is, now I've pulled that estrogen down across the board further by helping phase one here still, but also helping methylation. So phase one and phase two, see how that methylation is so much higher? Let me show you this. So the methylation now is close to like normal. So I'm almost a normal methylator now with a little bit of help. And if you compare this progression, you can go to the bottom and see that's just native me at the 19th percentile for methylation. Then we increase the estrogen load and my methylation comes down. It can't keep up. Then I make that worse by adding 2-hydroxylation and really increase that 2-hydroxyestrogen. Now the methylation's clear down at the 4th percentile. And then by targeting that methylation with trimethylglycine, that really popped up, which is a really good thing in terms of getting rid of those catechol estrogens. So again, that's a male case, of course, but it shows you, and the reason I use that one as an example because I just finished looking at this. So I thought it was a really interesting example of how both methylation and phase one, if those are compromised, they can increase your parent hormones. And as we see in PCOS case, if that's the case, it can exacerbate the risk that brings along with it for your female patients. So why do estrogen metabolites matter? Because if you have sluggish metabolism, it's going to increase your parent estrogens, which are the strongest, of course. And if 16-hydroxyestrogen is dominant, it brings with it estrogenic impact. It's less estrogenic than estradiol, but much more estrogenic than the rest of the metabolites. So that's worth paying attention to. Now, as we go through the Dutch test and we think about PCOS, it won't stall on this for too long, but there's an interesting story that a lot of these organic acid markers that we look at sort of fold into the PCOS story, whether it's B12. If you have high estrogens, it tends to make your xanthuric acid go up because it can actually induce a B6 deficiency. So it's nice to be looking at these things at the same time. We've got our biotin marker, which was added exactly for cases like this. Why? Because if you make a lot of DHT, what's one of the things that you can see is hair loss. And if you have hair loss, that can also be caused by biotin deficiency. So we added a biotin marker so that if you have an overt biotin deficiency, we can be looking at that and uncovering that at the same time so that there's more a higher likelihood of getting clinical success when you go to address issues like that. So there's an interesting story. Indican is a gut marker. We see higher estrogen with higher indican because it indicates a gut problem that is going to prevent you from clearing your estrogen. So a lot of these tie in, and when we bring in Dr. Kelly here in just a second, we'll talk about those. And that's what I invited Kelly along for, is because she is an expert in how to treat these patients that have PCOS. So Kelly, thank you for joining us and wading through my diatribe so that you could contribute some really practical words for our providers who really, I'm sure, want to learn not only this information, but how do we treat people with PCOS. So welcome to the conversation.
Thanks for having me. And that was great. That was very helpful, and I loved seeing that example. Even though it was a male patient, even though it was you, it was like super helpful to see all of that metabolism and how DIM affects it and trimethylglycine. So thank you for that.
Yeah, what our patients and providers don't often get to do is intervene one variable at a time and test in between, right? It gets a little expensive. So I figured I could do that with myself and show a step-by-step story there. But what I'd love to hear from you is some of the questions that I'm sure our providers have in terms of, okay, let's get practical. So I've got PCOS women. Like, what do you, as an expert at helping these women get better, like, how do you actually go and address some of these treatment questions based on different types of results? So the first question I had for you is, this particular woman has a progesterone serum equivalent of 8, which means the following: she ovulated, she makes progesterone, but not enough. I could show you another woman's results who also has PCOS, has maybe estrogen levels that are the same, but instead of progesterone of 8, it might be 0.8, meaning that would imply she didn't ovulate at all. So my question for you is, as it relates to the progesterone side of the story, how do you approach women differently when they are making progesterone and ovulating, but it's inadequate, versus a woman who's not ovulating at all in the PCOS group?
Right. Yeah, that's a really good question. So about 10% of women with PCOS ovulate every month. And those women, in my opinion, it might be easier to improve their ovulation, improve their corpus luteal health, and improve their progesterone production. But it really depends on the person, on the patient. And it really depends on their diet and lifestyle and what they've already tried, what they're currently doing. How invested in their health are they? So, in a woman who's ovulating every month, we might do things to just help improve that corpus luteum, like I said before. We might do things that support the circadian rhythm. I love to start with sleep and circadian rhythm because when you support the circadian rhythm, which is our 24-hour rhythm, you end up supporting our infradian rhythms, one of which is the menstrual cycle, right?
Gotcha.
So, all the things that go along with circadian rhythm support, including going to bed at the same time, waking up at the same time, getting adequate sleep, getting enough deep sleep and REM sleep is really, really important. And there's a lot of things that women can do in that respect. There's also other things you can do to support ovulation, supporting mitochondrial health, supporting ovarian health and follicle health with antioxidants and melatonin. Some people use evening primrose oil. People might avoid NSAIDs around the time of ovulation because that can affect ovulation. Even eating vegetables and fruits that are really orange or yellow. They're high in lutein, which makes sense, right? The corpus luteum needs lutein for its health to make lots of progesterone. Um, if a woman is not ovulating, so like you said, if her progesterone came back at like 1 and we determined that she wasn't ovulating frequently, or maybe she was only ovulating 4 times a year, sometimes I really like having women wear these wearable devices like the Aura Ring, for example, because then they can tell if their basal body temperature goes up, then they
Hmm.
likely ovulated. So, like if you see that basal body temperature go up by half a degree or a degree for about 2 weeks, then you can say, oh, you ovulated. And if they're not ovulating very often and they're not being exposed to progesterone, then we know it could set them up for higher risk of autoimmune disease, including Hashimoto's. Progesterone is also really calming. It helps women with their mood. It helps with sleep. Progesterone is great for bone mineral density. It opposes all those proliferative effects of estrogen. So if women with PCOS are not ovulating or not making enough progesterone, they're going to have that higher risk of endometrial hyperplasia and cancer. So if they're not ovulating or it's really rare, I really look at their diet and lifestyle. I look at what they're doing already. I look at what supplements they're taking. And then based on that, usually I'll do more work to try to get them to ovulate more frequently and make their progesterone on their own. But if we're not having success, I think that's when it becomes really important to supplement with bioidentical progesterone. And usually we'll cycle it. So we'll have women take 100, 200, sometimes even more than that milligrams of oral micronized progesterone about 12, 14, well, usually around 12, 14 days per month, or
Okay.
yeah, usually per month. Some people go by the moon cycles, but the month is easier.
So you're trying to get women ovulated and sort of spending like a small short season trying to get them making their own progesterone before you go and add, for most women with PCOS, before you go and add exogenous progesterone into the equation. That's your general approach there.
Yes, yes, but it really does depend on the patient preference, their current diet lifestyle, what they're willing to do. I might jump straight to the progesterone if it makes sense for that patient. Or
Do do
some
the
people
do
do
the Go ahead.
some people do oral birth control for PCOS. But one thing about
Oh, right.
oral combination birth control is you got to be careful about what progestin is in there because some progestins are very androgenic, like norethindrone. One time
Right.
I saw a woman
Right.
come in on norethindrone progesterone or progestin, synthetic progestin. And that one is actually more androgenic. It's going to make those high androgen symptoms worse. But other ones that are anti-androgenic are more like drospirenone. So oral birth control, it is an option. It's not usually my number one choice, but it is an option.
Right, which also good to make sure people are aware that if they're already on those products, of course, you're gonna pretty much always see them as anovulatory in terms of progesterone because they're taking a progestin. So there could be a debate there whether a progestin is the appropriate treatment for a particular woman. But I think a great point that if it
Yeah.
is the choice, make sure that you're selective and using one that doesn't bring androgenic impact to a woman who's already probably got plenty of that going on and very likely too much.
Yeah,
Okay,
that brings up
yeah,
another great point because progestins are not bioidentical, right? And we
right,
know that bioidentical progesterone, our own endogenous production of progesterone, actually helps calm down the immune system. So, for example, it lowers the production of that pro inflammatory cytokine IL-6, whereas estradiol is more pro-inflammatory. It stimulates the immune system and it's going to stimulate that production of IL-6. So in women in PCOS, a lot of times they have high androgens, and the high androgens might be coming from the ovaries, they might be coming from the adrenals or both. And let's say you put this woman on a oral contraceptive with a progestin, it might lower her estrogen, but it might not. And if she's
gotcha,
got still higher baseline estrogen, but no bioidentical progesterone to oppose it, just the progestin, which I don't believe the progestins work in the same way with the immune system, you might run into
gotcha,
some issues there when it comes to
gotcha.
autoimmune risk.
Okay, great. Yeah, that's great. All right, let's turn to the androgens for a second. So,
Yes.
tell me this: I've got a PCOS woman who's just making too much androgen,
Yeah.
so lots of DHEA, maybe lots of testosterone, and then another woman who maybe has normal-ish levels of androgens, but she's really pushing it down the 5 alpha pathway. So I'm thinking I've got high 5 alpha androstenediol, lots of cellular DHT going on, but not necessarily too much androgen. And then you could have a woman with both. So high androgens, high 5 alpha, or both. Like as you think your way through, like how I'm actually going to treat a woman or intervene, how would you approach those differently?
That's okay. That's a great question. So we'll start with the woman who has normal testosterone, normal DHEA, but maybe she's pushing more down that more potent androgenic 5 alpha reductase pathway.
Right.
So perhaps her DHT levels are elevated or her 5 alpha androstenediol is elevated on the Dutch test. So these women are really interesting because a lot of times they go to providers, they get their testosterone and their DHEAS measured in the blood, it comes back normal, and people are kind of stumped. Like, why do you have these high androgen symptoms? But then when you look at the Dutch test, you see that, wow, she's really pushing down that alpha pathway. Her DHT is high. Her 5 alpha androstenediol is high. No wonder she's having symptoms of high androgens, right? So in this case, what I try to do is I know that her ovarian, her adrenal production of androgens are normal. That's not the issue. The issue is the 5 alpha
Right.
reductase activity. It's too high.
Right.
So in this case, I really tried to work on, of course, treating the cause. That's what we're always trying to do. And we know that insulin resistance pushes the alpha pathway. We know that obesity pushes the alpha pathway. Stress can do it too. And there's one other one, inflammation. So I
Right.
might look at her hemoglobin A1C, her fasting glucose, her fasting insulin, her CRP. I might do a little more investigation to see, does she have insulin resistance? Does she have high inflammation? Ask her about her stress. Look at her cortisol on the Dutch test. Is it high?
Right.
Is it low? And try to work on that foundational support first. We also have 5 alpha blockers. Some are pharmaceutical, like finasteride or
Right.
dutasteride, but we have a lot of natural ones too. For example, saw palmetto is a great one. Pygeum, nettle root, not leaf. A lot of times we're using nettle leaf for allergies, but nettle root is for 5 alpha
Mm.
reductase. Green tea extract, the EGCG, and reishi mushroom. I always find
Do
reishi mushroom really interesting because on the opposite end, some women have low androgens and they have low libido, maybe
mm,
low mood, low muscle mass, hard for them to exercise. And some of them are using reishi mushroom in their coffee every morning. And it's probably, depending on the
ah,
dose, it could be making their androgen activity even worse. But it is something we
right.
do use in PCOS that can be advantageous.
You mentioned 4. Do any of those 4, I have no idea. Do any of those 4 happen to have other benefits in a PCOS case to where you tend to lean in the direction of any of those in particular? Or because they're maybe stronger?
Yeah, that's a good. I mean, saw palmetto and nettle root are very, very common. I'd say those are the most common ones that I see
Okay.
people using. Reishi can also affect adrenals, can affect immune system. So sometimes people will use reishi in that respect. Green tea
Gotcha. Okay,
extract,
so
highly antioxidant.
those are great options. So I've got a woman who's got high 5 alpha. I use those successfully. Now, the next woman I see has PCOS. She's not a 5 alpha metabolizer. Like me, I'm a 5 beta. I push everything down the beta pathway. So if you have elevated testosterone, elevated DHEA, but there's not a 5 alpha preference, like how would you approach those women differently to try to get those androgen levels down, assuming they've got some symptoms that are going along with that? How do you approach that?
Yep. Well, okay, first of all, and I'll make this quick, but first of all, I really make sure PCOS was diagnosed correctly because you really do
Mm,
have to rule out some other major ones are Cushing's disease, hypothyroidism, hyperprolactinemia, and non-classical congenital adrenal hyperplasia,
right.
NCAH. NCAH, it's a genetic issue. The most common is 21 hydroxylase deficiency, but it's more common than we think. And a lot of women with PCOS are misdiagnosed. They actually have this genetic issue, this non-classical congenital adrenal hyperplasia, and the treatment would be very different. They usually do smaller doses of glucocorticoids for them. Um, but so, number one, try to figure out why these androgens are high. And even in women like correctly diagnosed with PCOS, if they haven't had their prolactin checked in a while or their thyroid checked in a while, I'll still do that because we know that
Gotcha.
with hypothyroidism, when our thyroid hormones are low, TRH, thyroid releasing hormone, goes up. So the brain releases TRH. TRH goes to the pituitary and it tells the pituitary to release thyroid stimulating hormone, but also prolactin. So if we're hypothyroid, it can increase the chances that we have high prolactin. And high prolactin can do two things. Sometimes it suppresses GnRH, the gonadotropin releasing hormone, which can suppress LH and FSH and suppress hormone production. But, it can also cause that zona. So, the zona reticularis in the adrenal glands. That's the zone that makes DHEA. It can
Right.
overstimulate that zona reticularis and cause an increased production of DHEA. So I'm always trying to, of course, treat the cause in this situation. Um, some people will still do 5 alpha blockers, even if they're really balanced between 5 alpha and 5 beta. If you have high DHEA and high
Right.
testosterone, you're likely also to have high metabolites in general. So they might still use the 5 alpha blockers to try to lower androgen
Right.
activity in the body. There's other things you can do, of course, to help lower androgens. There's some research on chamomile extract, on spearmint tea, 2 cups a day. We're going to regulate blood sugar. You know, in women with PCOS, when their ovaries overproduce testosterone, if they're insulin resistant, it's going to make it even worse. So, working on those blood sugars is going to be helpful, lowering inflammation, supporting that circadian rhythm, kind of going back to the sleep, all
Gotcha.
those foundational supports.
Gotcha. Now let's go to the heart of what we've been talking about, autoimmunity. So how does it do you end up typically dealing with women who have PCOS who are already on the other side of autoimmunity, who have like let's just go with Hashimoto's. When women co-present with Hashimoto's and PCOS, how does that change your approach to your management of their PCOS?
Yeah. So, I mean, a lot of times we're still going to try to balance that progesterone to estrogen ratio. If they've got high baseline estrogen, we're going to try to lower that and try to improve progesterone. So, improve that balance is going to be important. Sometimes people will add on, there's some research around like myo-inositol and selenium to improve Hashimoto's. And the interesting thing is, myo-inositol, a lot of us know myo-inositol for PCOS treatment because what does it do? It helps
Right.
regulate blood sugars and helps lower androgens. And what happens when you regulate blood sugar and lower androgens? It tends to lower our estrogen too. So I wonder with the myo-inositol, is it improving Hashimoto's because of a lot of reasons, but maybe one is it's helping to lower estrogen and improve that progesterone to estrogen balance. Um, but in women with Hashimoto's, if they already have autoimmune disease, I might also look at the estrogen metabolism. And if they're pushing towards that more proliferative 16-OHE1, I might do a lot of things to try to help lower that. So there is some research showing that people with rheumatoid arthritis and lupus tend to have higher 16-OHE1. And we know that lupus antibodies actually
Right.
bind 16-OHE1. So it may have a stimulating effect. The 16-OHE1 may have a stimulating effect on autoimmunity. So we'll do a lot to help lower 16-OHE1. There's a lot you can do to help lower that preference. And moreover, I might do like more of a strict avoidance of gluten. Sometimes that really helps people with Hashimoto's, and look at their cortisol. Because if you think about it, cortisol really helps suppress
Right.
immune activity. And if I have someone with autoimmunity and I look at their page 5 on their Dutch Complete or Dutch Plus, and they've got low diurnal cortisol or like a flow flat line, I'm going to be a little more worried about them not having those protective effects or those suppressive effects of cortisol around. And there's actually some research showing that women with, I don't know if it was women, maybe men and women with rheumatoid arthritis, if they had low cortisol, if they gave them oral hydrocortisone, I think they were doing about 20 milligrams per day, it improved their rheumatoid arthritis.
Hmm.
So a lot of times we do see
Oh, that's interesting.
PCOS patients with high metabolized cortisol, high total cortisol production. In that case, I wouldn't use oral hydrocortisone. But if I came across a patient with just low cortisol across the board, I might actually use hydrocortisone, which could help lower their autoimmune activity.
Gotcha. Yeah, that's really interesting and I think super insightful. Um, Speaking of insightful, I wanted to put you on the spot on this question because this is something that confused me that I would imagine you will have some insight to. Um, so, sarcopenia and PCOS. Um, with sarcopenia, to me, it makes sense that higher androgens would be somewhat protective of that. But PCOS women get more sarcopenia, and I was shocked by this stat. Over 50% of PCOS women are defined as sarcopenic obese. So again, in my mind, simple chemist, in terms of how I think linearly, higher androgens should be a good thing in terms of not getting sarcopenia, which PCOS women tend to have. So could you explain what your theory would be on why women with PCOS would actually get sarcopenia at a higher rate?
Yeah, there's a few things that you see in the research. So yeah, we tend to think of higher androgens as supporting muscle mass and supporting exercise, but women with PCOS,
Right.
right? They tend to have high inflammation and they tend to be overweight. We tend to see more obesity. And we know that visceral adiposity, especially if it's around the abdomen, it's more inflammatory and it's going to release more pro inflammatory cytokines. And inflammation can contribute to sarcopenia. And sarcopenia, remember, is we have a lot of fat tissue, a lot of body fat percentage, and then low muscle mass. Um, Insulin resistance. So insulin resistance tends to break down muscle. And we know that women with PCOS are oftentimes more insulin resistant. On top of that, women with PCOS tend to have low vitamin D, and low vitamin D helps promote muscle
Oh,
growth. And they've actually seen this, that when they give women with PCOS who are sarcopenic, if they give them vitamin D, they see improved outcomes. So I think it's a
oh,
mixture
that's
of
fascinating.
inflammation.
So
Yep.
as with most things, multiple variables, but insulin, inflammation, yeah,
Yes. Insulin,
yeah,
inflammation,
that's really
obesity.
fascinating. Well, that's super helpful for me because I found that confusing when I ran into that, looking at just the distinction between the PCOS group and those that don't. So as we wrap up, this is super good insight. I didn't want to give you too many topics to potentially think about, but what I wanted to do is just load this up with things that are common treatment targets, particularly for this group of PCOS. And I thought maybe you could just pick one or two. I'd love for you to finish with the elevated estrogen one because that's sort of the heart of the topic today. Is how are you actually treating women that tend to have higher estrogens, higher 16 hydroxy? But before you do that, I thought maybe you could pick one or two of these that tends to either be super common, super misunderstood, or where there might just need to be a little bit of a more help from you and the experience that you've had in terms of getting women with PCOS on a better track as it relates to, again, one or two of these, and then maybe you could finish with the elevated estrogen. I'd love to know, just practically speaking, what you actually do with women who tend to have high estrogen, who also have PCOS.
All right, sounds good. I don't want to pick one or two. I want to talk about all of them, but I'll pick one or two. Okay.
All right, I'll go three
Let's
hours.
let's make this a 3-hour webinar. Okay, I am going to pick low melatonin. Low
Okay.
melatonin. So people who are obese tend to have low melatonin. And a lot of us think about melatonin for the sleep wake cycle, but we don't realize melatonin is also involved in regulating our blood sugar and a lot of metabolic processes. It's also antioxidant. So when I see low melatonin on the test in a woman with PCOS, I definitely want to work on improving that. You know, the the sleep wake cycle, the circadian rhythm support, like I said before, is I think very, very important for our women with PCOS. If you think about it, it's so interesting, but when we get adequate sleep, it really does improve our overall detox. It supports our immune function. It supports our metabolic function. So when we sleep, we primarily transition to burning fats, burning triglycerides, and lipid oxidation peaks at night. And people who don't get enough sleep, they tend to have higher stress. They tend to um, overeat, especially foods high in cholesterol, and they tend to have more issues with regulating their blood sugar, right? But also the immune system. So, for example, neutrophil activity peaks at about 9 p.m., and lymphocyte activity peaks at about 3 a.m. So, going back to melatonin, I want to optimize melatonin to not only optimize the sleep wake cycle, which is going to impact metabolic function and immune function, but also is going to affect that insulin resistance directly. So there's a lot of things we can do to help improve a low melatonin. I don't know if we have time to get into that right now, but that's one that I do focus on.
I just add this because it made my head almost explode with confusion. Is one of the studies I found, or combination of studies or something, was claiming that women with PCOS tend to have higher levels of melatonin production, but lower levels of melatonin either in the ovary or in the oocyte or something like that, which I would imagine plays into like its anti-inflammatory effects or something like that. But I thought, whoa, I didn't get a chance to sort of dig at that, but I thought that was really fascinating that maybe there's a compensatory mechanism of trying to produce more melatonin, but yet still being deficient in that key space of the ovary. And so then if you find a PCOS woman who happens to be deficient in melatonin, then I would imagine even more so in that, in that particular tissue. So that was new to me. So.
Oh, wow. Yeah. That's fascinating because we know melatonin really impacts ovarian health and follicle health. Okay. So let's talk about
Yeah,
the elevated
interesting. All right,
estrogen.
melatonin. What's next?
Estrogen. I'll talk about
Okay.
estrogen because we touched on a lot of these already, and estrogen is really going to pull everything together because a lot of things kind of tie into estrogen. So elevated estrogen, we definitely want to try to lower estrogen. And I did want to say that some women with PCOS, especially if they're overweight and if they've got high androgens, their baseline estrogen can be elevated. So I have seen women who have
Right.
PCOS who don't ovulate often, but their estradiol on the Dutch test is 3.5. And just as a reference, for a woman who's not ovulating, usually her estradiol is between 1 and 2. And we know that the luteal range is 1.8 to 4.5. So I'm seeing PCOS women who are not ovulating, not cycling, with just a continuous baseline estrogen from day to day up in the luteal range around 3.5 with no progesterone
Gotcha.
to balance it. These are the
Right.
women I get very, very worried about for developing Hashimoto's, developing other autoimmune conditions, developing cardiovascular disease and endometrial hyperplasia and cancer. And these women, when they hit menopause, like a lot of people say, oh, don't measure hormones in menopause, they're going to be low. They're not always low. Like estrogen is not always in that postmenopausal range. I have seen postmenopausal women
Mm.
with estradiol in the luteal range, up to 2 or
Wow.
2.5. And when you look at the data, well, the data says women who are obese have that increased risk for endometrial hyperplasia and cancer. But women with PCOS, if they have high androgens and they're overweight, all the extra fat tissue has aromatase activity. And it's going to take those high
Right.
androgens, aromatize them to estrogen in the periphery. So they tend to have that higher baseline estrogen. And sometimes in these women with PCOS, when they hit menopause, I don't even give them estrogen. You just give them progesterone. But
Right.
anyway, so we want to lower the estrogen, right? And in the beginning, you did a really great explanation of supporting phase 1 and phase 2. You talked about trimethylglycine and DIM. There's a lot of other things we can do to help support estrogen detox. A few are ground flax seeds, which also might help elevate sex hormone binding globulin and bind up more of that free testosterone. Cruciferous
Mm.
veggies, eating them on a daily basis, I think is important. Our broccoli sprouts, our sulforaphane and glucoraphanin, rosemary, soy from a good source, fish oil, and avoiding the high sugar, high alcohol diet. So supporting estrogen detox. And when we look outside the Dutch test, supporting phase 3, which is in the stool, making sure they have adequate bowel movements. Sometimes, even if women are having one bowel movement per day, I might even try to get them to have 2. I might even increase the cruciferous
Mm.
veggies or the fiber, might give them a little magnesium glycinate to also support their methylation to get them having just 2 bowel movements a day. Usually one is pretty good, one per day. Um, but then we can start to think about, well, what's causing the high estrogen? We know that androgens like DHEA and testosterone can aromatize over to estrogen. So we can lower the androgens.
Right.
We can lower aromatase with things like white peony and licorice. I think I'm saying that right. Um, we can lower alcohol intake. That's going to increase estrogen. We can lose weight. When we're overweight, we tend to overproduce estrogen. We can regulate our blood sugars, can support that circadian rhythm. There's so much we can do to help lower estrogen in the first place, even avoiding xenoestrogens in our environment.
So when I'm asking you what do you do with a PCOS woman because she has insulin issues, because she has high androgens? A lot of the things that you're doing overlap with the things you're saying help elevated estrogen. So that's a nice observation that before you even deal with metabolism, which you should, um, dealing with PCOS holistically also is going to help at the same time to lower those estrogens. And then you're listing some really good additional strategies that you can take, optimizing phase 2, methylation, phase 3, all of that. So that's a lot of really good and practical approaches, again, that you may be taking anyway with your PCOS patient if you're going to be having success with them. So that's great. Anything else for the estrogen that we should be thinking about in terms of strategies that you employ, or other maybe tests that you're looking at that might be insightful for sort of winning that battle to really get that down, if we're thinking of that in terms of specifically increasing risk of autoimmunity and some of those other things?
Yeah, I would say, I mean, stool testing, that's a big one. Some bacteria will actually produce enzymes like CYP3A4 that increase that 16-OHE1.
Hmm.
Um, also, some
Gotcha.
bacteria are more likely to produce beta glucuronidase. And I'm sure a lot of people have heard about beta glucuronidase, but beta glucuronidase, if it gets too high in the gut, in the stool, it'll, instead of the estrogen being eliminated in the stool in the toilet, the beta glucuronidase will cause it to be recirculated, reabsorbed back into the body. So a lot of times we're looking at the stool testing, we're looking at beta glucuronidase. If beta glucuronidase is high, calcium D-glucarate can be really helpful, but there's also a lot of other things we can do with diet and
Right.
lifestyle to help lower beta glucuronidase. It's not just calcium D-glucarate, luckily.
Right. Okay. Well, that's some really good tips there. Again, I know we could go on forever about the other things that are related in terms of treatment that are common for these particular patients. But thank you for filling in so many of the blanks in terms of how we're treating those patients, and not only to help them with PCOS, but also hopefully helping them to avoid slipping into some sort of autoimmune condition, which is just going to compound the problems and challenges that they have as a patient, and that you have as a provider for helping them on their journey to wellness. So I hope this has been helpful and insightful for all of you. We're still learning on some of these fronts, some really interesting data coming out here on this particular topic, so we want to share that with you and continue this conversation. So thank you for your time and expertise, Dr. Kelly, and thank you to everyone
My pleasure.
for paying attention here. And please do follow up with us if you've got questions on these particular topics, or how to use the Dutch test in your practice. So thank you for your time and attention.
Thank you for joining us for this insightful webinar with Mark Newman, CEO and founder of Precision Analytical, and Dr. Kelly Ruef. We hope you learned something useful. Watch your inboxes tomorrow for a link to the recording and to access the resources we shared today. You can learn more about the research behind the Dutch test at dutchtest.com/research, and make sure to visit the Become a Provider tab at dutchtest.com to register for an account so you can gain access to even more hormone education and research. Follow at Dutch Test and subscribe wherever you get your socials to stay in the loop for upcoming webinars and podcasts.